terms of also financial investment, is very, very important in order to develop a sustainable laboratory service. Laboratory medicine, modern laboratory medicine, is the foundation of modern medicine. More than 70% of the diagnosis in medicine are built on laboratory test results. So without laboratory test results, there will be no progress in medical service. This is with regard to cancer service, this is with regard to cardiovascular service, dialysis, intensive care units, and so on. They are all based at the very end on a very sustainable and very good, very modern laboratory service. And this requires quality in the service. And this is why we are here to explore from the German side opportunities and possibilities for collaboration with your government, with your organizations, with the hospitals, in order to help to improve the quality standard of laboratory medicine. That is the aim and the goal of our session here today, and again a warm welcome on behalf of our German organizations. And I'm very proud that we have put together a panel of distinguished speakers today. So we will have 4 presentations. The first presentation will be given by Mr. Said Abdul Kizili. Which one? My presentation, okay, thank you, Anja. So my presentation will be the first one, followed by the presentation of Jacob Lusekelo, which I will introduce to you also in a moment. And then we have Mr. Saif, and then we have Dr. Kessler here on the podium. Okay, I will introduce the speakers to you before they give the presentations. Okay, so that would mean I should start with my presentation now first, of course. Very good. So maybe, I don't know, do we have, no, this is not the right presentation. No? Yeah, that's the right presentation. Okay. And can you go into presentation mode? Yes. Okay, so why is, unfortunately we don't have a podium here, but I think this is, oh, the podium is coming. Right on time, excellent. So we are just giving our colleagues a minute to set it up. Can I move the slides from here, or I'm moving the slides? Thank you. That's okay. Ah, okay. Very good. So we have some delay over here. Yeah. So thank you very much. As I already mentioned, the title of my presentation is "Why is quality control and proficiency testing so important? The impact of quality control on clinical services." So, okay, my conflict of interests. So external quality control is actually aiming to improve the quality of diagnostics. It is defining a standard that service providers are expected to achieve, and quality control is helping to identify problems relating to methodologies, relating to assays, relating to the laboratory management, related to the laboratory procedures. And actually, the organizations which are providing external quality assessment, they play also a very important role in education and training. So not only naming, the laboratories from not fulfilling that criteria, but also helping to improve the service, increasing the service, and providing platforms for education and training. And the external quality program is also assessing the laboratory's ability to report appropriately, not only to send out the results, but also to help in terms of the interpretation of the results, in terms of the clinical meaning of all of this. The next slide, please. Maybe you can do it from the back. Can you move the slides? This is not working from this distance. Yeah. So, of course, you know there are many different quality providers, quality organizations, and the surveys vary between disciplines, organizations, and analytes, and the outcome may be determined also by scientific opinion. Next slide. Scientific opinion and the analyte. And here I will give you a very, very important example. These are tumor markers. You see here on the top there are 5 different tumor markers: CA53, CA99, CA125. You see 5 different tumor markers, and in the first column you see quite a number of different manufacturers, different service providers, different companies providing these assays. And what I have boxed here on this slide are all the tumor markers evaluation of EQA results, which are below 80% of passing rate. Below 80% of passing rate. And you see this is a substantial number of assays which do not pass the needed quality standard, the needed quality requirement. And what you can see here is that on the next slide, these results, this is not working for you, that we have, of course, an intra-method precision of most analytical platforms that is accessible within a method, within a test. But when it's come to inter-method variability, we see here really the need for standardization and harmonization of these methods, and the need for international reference materials. So it does matter which test you are using in order to analyze tumor markers, for example. And if we take this, next slide please, and if we take this as an example, tumor marker diagnostics depends usually on immunoassay platforms. If we take this as an example, then we can really state that we have a general issue with all kinds of immunoassays in the laboratory. Immunoassays remain vulnerable. We have intercollective differences due to manufacturer-dependent procedures. And Stefan Holdenrieder here from Germany, he just published a very nice paper indicating a huge degree of variability for AFP, for instance, more than 23%, and for carcinoembryonic antigen, more than 88%. So we need a process of harmonization leading to good robustness and low intra-assay variation. And with regard to immunoassays, we have particularly challenges because of cross-reactive substances, antibodies against analytes, and/or antibodies against reagents. So let us just take this as one example where we need urgently better tests, better improvement, higher improvement of our tests, of our assays. And I will give you an example also from Europe here, indicating how important, how important standardization is. This is results from the standardization program in Spain. And you would think that Spain, a European country, has already such procedures available for a long, long period of time, but that is actually not the case. They just started with laboratory diagnostics only a few years ago, and they published the results of the 17 most common, most frequently measured analytes. Just wait. I have to set this up again. So this is the result of the most common, most frequently measured 17 biochemistry tests. You see them here, and only one test really passed at the beginning of the implementation of this program. We required a standard, and that was creatinine, followed by CK and gamma GT assays. All the other tests did not pass and not reach the desired levels of quality control. This is even in Central Europe, and only after a very few years of implementation of this program, the quality significantly improved very rapidly. Now I would like to take you to another area. We have talked a little bit about immunoassays, in principle, tumor markers in particular, and now I would like to introduce you to lipid standardization. In the United States, there was already in the 1980s of the last century an approach to lipid standardization, the lipid standardization program. And this lipid standardization program was started in 1980 and was performed for 30 years until 2010. So we have here now 30 years of overview of what can be achieved with lipid standardization program in order to combat cardiovascular disease, myocardial infarction, stroke, and so on. And this is a remarkable result, which has been even published in the New England Journal of Medicine a few years ago, indicating that such a standardization program can lead to a reduction in heart disease mortality, and in this case, over 30 years, 30%. 30% reduction in heart disease mortality due to the assessment of high cholesterol and implementation of secondary prevention such as statin drug programs. And here you can see in 1985, at the beginning of this program, 28 out of 30 methods did not pass the required levels of quality of standardization. That means over 90% of the assays did not achieve the required results, and in 2009 this could be reduced to only one method out of 20, so 19 methods now pass the desired regulatory results. And this improvement of quality resulted in a reduction of misclassification of patients. LDL cholesterol levels, total cholesterol levels, and other levels as well. And in 2000, has been published just a few years ago, in 2000, 3.9% of males were misclassified in this program, and that's a lot. That is about 1 in 20 males was misclassified because of either falsely high or falsely low reports, and this could be reduced within 6 years, from 2000 to 2006, to already only 2.3% of the males. And if we now consider the contribution of quality to the overall program in the United States, the overall program of combating cardiovascular disease, and if we consider the contribution of the laboratory only to be 0.5% or 1% or even 5% of the entire program, we achieve here a cost benefit of several billion US dollars, up to 60 billion US dollar over the period of this observation over the last 30 years. So one can even measure the financial impact, the financial benefit of quality improvement in this regard. And another example in this regard is here in Germany. So we have here the analysis of health and economic impact of improved glucose, blood pressure and lipid control among German adults with type 2 diabetes. Type 2 diabetes is a very high burden here also in Tanzania, and the improvement of the quality of measuring glucose, blood pressure and HbA1c levels and LDL cholesterol is significant in terms not only of improving health but also by reducing the costs in this regard. So over 10 years this could reduce the German healthcare expenditure by over 1.9 billion euro and gain approximately 270,000 quality years over such period of time. So a significant impact of quality on the service. Another example is the little measurement of calcium, for example. And this has been reported by one of the diagnostic companies running and offering calibration materials here. We estimated the cost for systematic errors of really minute differences in calcium measurements to be between 60 and about 200 billion US dollars. And now I give you another example. It is not only a matter of importing results back from the laboratory to the doctors, to the hospitals, to the service providers. It is also a matter of interpretation of the results. What do the results mean? So the laboratory has also the obligation to give an interpretation. What do these results mean? And here we have another very important issue where we have to improve the quality of the reported results. And I will give you here one example for cardiac markers. What these investigators did, they sent out 3 samples to the laboratory. Sample number 1, number 2 and number 3. And you see in these 3 samples they had different concentrations of troponin, different concentrations of CKMB, and different concentrations of myoglobin. So they asked the laboratories, first of all, of course, to measure these 3 analytes in the samples, but not only this, they also asked the laboratories to report an interpretation, what the test results mean. And here, only for sample number 1, you see the scatter of reports, ranging from myocardial damage until no comment or even normal reports in this regard. So here you see some of the interpretive comments. Some laboratories reported acute coronary syndrome, others reported AMI, and on the last you see here, please phone me if you wish to discuss these abnormalities. So you see there's a huge scatter of interpretation and results. So that means we have 2 important obligations with regard to quality issues. Number 1, the analytical precision, and number 2, the medical interpretation of the results, and this requires really education and training. And such training is, for instance, provided by our global organization, the IFCC, the International Federation of Clinical Chemistry, and they performed here a survey around the globe to see how quality control programs have been implemented around the globe. You see here in the middle, TFLM in Europe, of course, lots of programs have been implemented, but on the left-hand side, the African Federation of Clinical Chemistry reported only 2 programs in all over Africa, which have been implemented so far. So this indicates really the need to have more programs and to have better programs available in all of these areas. And finally, I will give you another example from tumor screening. Tumor screening here for the human papilloma virus. Again, this is 2019 HPV DNA proficiency panel screening. You see here the WHO results, all of the screening centers here which participated in this survey program, and you see only 3 dots here overall in Africa. 1 dot is here in Tanzania, the other one is in South Africa, and the third one in Western Africa. So really a lack of proficiency testing for HPV. And here you see the results of HPV testing, again broken down to the different areas around the world. And you see here the passing 78 laboratories participated with 110 data sets and 38 different assays. And you see again proficiency, the level of proficiency testing really depends on the region. The lowest rate of passing again is here in Africa. So that matters. And you can see here on this time scheme that following the implementation of proficiency testing for HPV in 2008 and 2010, you see an immediate jump to improved quality from about 30% up to 60% and even further up. So implementation of quality issues and quality programs increases safety for the patients and reduces complications and reduces costs. So the reasons for potential problems with unacceptable results are multiple. And this is just an overview about different reasons which need to be analyzed once you get your results back from your organization. Can be human errors, methodological problems, equipment problems, technical problems caused by personal errors, the problem with QT material as such also happen. So many issues. It is now the responsibility of the quality managers in the laboratory to really go down and assess what is the reason in your particular case, why did you not pass the respective levels already. And that is a huge challenge. So in summary, errors are costly. Patient safety, false clinical decision making, and expensive consequences. So the impact of errors, is really underestimated in medicine and is underestimated still in many countries around the world. When vice versa, it is really worthwhile to invest in quality and to improve the quality in order to reduce the misclassifications and to improve patient safety and to improve health over here. And as I said at the very beginning, we are here from the German Society and the German Reference Institute are here to start, hopefully to initiate collaborations with your bodies of authority, the Ministry of Health and other organizations in order to help to improve the standard of the level of service and the level of safety and to implement better quality programs also here to your region. And with that, I would like to thank the team of the Reference Institute, Gunter Schabio and Anja Kester, and also the board of our German Society for Clinical Chemistry and Laboratory Medicine. And I'd like to thank you for your attention. Thank you very much. So I think we should leave the discussion to the end. We have 3 more presentations to come. And now I would like to ask Mr. Jacob Lusikelo to the podium. Mr. Jacob Lusikelo is representing the Ministry of Health, the Diagnostic Services Unit. He is overseeing the East Africa Regional Center of Excellence in Biosafety and Biosecurity. He has a long-lasting experience in biosafety and biosecurity issues, and he will introduce us to the situation here in Eastern Africa and in Tanzania in particular. Mr. Jacob, please come to the podium. Thank you.
Thank you so much. So today we are going to make you understand the quality of laboratory services. So I just passed through the coordination framework of the quality management system here in Tanzania and the services associated with quality management systems, and we are going to see the achievements so far in the country and challenges we are facing and the way forward. So, as we all are aware that the quality management systems formalized processes and procedures in the laboratory, and establishing quality management system requires commitment and dedicated workforce, infrastructure, and uninterrupted supply of reagents and EQA and calibration services. So I'm just going to talk about all these 5 pillars which contribute much in the quality management systems. So the first thing is the coordination framework. We need to have a very strong coordination framework in the quality management systems, and the country has invested through the Ministry of Health just to coordinate both public and private health facilities. And the Ministry of Health oversees the laboratories in stepwise approach. We term it as SNAPTA towards accreditation, because we are living in a country with limited resources, so we cannot just invest so much at once. So we are just going at stepwise approach with SNAPTA approach. And then we have invested in laboratory personnel and facility management to build capacity and to interpret and implement the international and national and international standards. And then we are coordinating the technical assistance partners and regional IPs in joint planning and annual evaluations. So in this view, I'm just going to give you how we coordinate the EQA framework here in Tanzania. So EQA is external quality assessments, where we produce PT panels and we share with laboratories just to make sure that they are in line with national and international standards, but also to identify potential pitfalls that can cause errors to patient results. So in order to do so, we have identified and dedicated 3 laboratories that would be the PT and EQA providers here in Tanzania. We have National Public Health Laboratory, I think you know and you are aware of it, and we have the Central TB Reference Laboratory and National Blood Transfusion Services Laboratory. And all these laboratories are coordinated through the appointed committee called EQA Technical Advisory Committee and oversees the EQA production, distribution, analysis among the 3 laboratories. So what NPHL is offering, my colleague will demonstrate further in the coming presentation, but just to give you a snapshot, NPHL offers PT panels for hematology, CD4, HVL, bacteriology, malaria sites, rapid COVID-19, HIV, rapid syphilis and hepatitis B. And then blood transfusion, they provide PT services for blood including serology. The Central TB Laboratory, they are providing PT panels for gene experts and TB microscopy. So that's the view of the EQA systems here in Tanzania. But the calibration services is provided by TBS, Tanzania Bureau of Standards, which has been accredited by SANAS, and the sole provider of the calibration services. But we want to scale up the calibration services to National Public Health Laboratory in order to be capable of calibrating auxiliary equipment. And now we have built capacity in NHL to calibrate equipment for speed and weight. So we are scaling up the services to include the temperature as well and pressure. And NPHL provides services for certification for safety cabinets in public and private test facilities. I'm happy to announce to you that the NPHL provides services within the country and outside the country. So we have been requested also to provide services in Burundi. In the inspections and audits, this is another component which is very critical, just to make sure that the laboratories provide quality services. And we have the private health laboratory board, which provides announced and unannounced inspections to all private health laboratories with respect to the established standards. So we have established the national standards for medical laboratories, and the PHLP ensures that all private health laboratories are implementing those established standards. And the Ministry of Health, through the diagnostic unit, they are providing announced and unannounced audits. So you'll see, I've mentioned about inspections and audits, they are quite different. So the audits is kind of supporting one, the facilities using the WHO procedure checklist. We have National Supporters Commission checklist and the pre-SAPTA checklist. So all these checklists are used during the announced and unannounced audits. And results of inspections, all the results of inspections are brought about during the annual review and annual planning. So we have a joint annual review and annual planning with partners, TAs, development partners, where we discuss the areas of improvement. I'm going to talk about the capacity building that we have invested so far in the country, and we are providing virtual biosafety and biosecurity training across sectors. So this is one of the milestones that we've made, where the animal health and human health come together and learn and discuss about biosafety and biosecurity. And these sessions are held twice per month, and today there is a session for biosafety and biosecurity. And we have face-to-face in-service biosafety and biosecurity through Regional Center of Excellence for Biosafety and Biosecurity. I'm happy to announce to you that the Regional Center of Excellence for Biosafety and Biosecurity East Africa region is located here in Tanzania, Dar es Salaam actually. So we are providing these biosafety and biosecurity trainings across East African region. Speaking of Ethiopia, Comoros, and all other countries that are neighboring East Africa. And we are conducting the annual trainings in troublesome areas in quality management systems, such as internal audits. We know how it's difficult if someone does not understand the standards. The method verification and method validation, identification of non-conformities, root cause analysis, and corrective actions. And we've included the risk management in our trainings, because nowadays, if you see the standards, it's a risk-based approach, and we need to identify pitfalls before they happen. And those are critical areas also we are looking at during our trainings. And we are providing biosafety certification training through Muhimbili University of Health and Allied Science in collaboration with NHL. In these pictures, you will see happy participants. They've just received certification from regional recognition certification from ASLM. We have state-of-art conference rooms dedicated for trainings, and the biosafety cabinets specifically for demonstrations. And this is the attendance of one of the sessions for biosafety and biosecurity training. So one session we can have more than 250 participants, and we are hosting in 5 hubs. So we can even train more than 900 laboratory personnel per session. And we have reached some gaps in the quality management system. So far, the 75 laboratories have been accredited, which are purely medical, and other 7 laboratories from the National Blood Transfusion Services. And we received 2 awards during the SLAMTA and SLM conference in South Africa, and one being the country with a large number of accredited laboratories through SLAMTA program, and the other one is the country with large number of highest percentage of accredited labs in the East African region. So those are some of the milestones that we have reached. Another milestone, I think you are fully aware of the joint external evaluation, which is the country assessment, and the country is being assessed in several other areas. And one of the areas that we were assessed within the national evaluation system was the quality management. In the quality management system, we scored 4 score, which indicates that we have demonstrated capacity in quality management system for human health, and we scored 3 for animal health, because we need to invest further when it comes to registration, assessments, and standards for animal health. And this graph shows you the tremendous achievement since we started the implementation of the formal quality management system in 2010 in Tanzania. You can see that we started investing trainings, and we started getting the outputs in 2014, where we had 4 accredited labs, and then now we are speaking about 81 accredited labs here in the country, including the blood transfusions. And the yellow line, this indicates the labs that we are subjecting them in capacity building. So the output of the capacity building through SLAMTA program is the blue line. So that's where you can see we are investing together with the outputs that we are getting. And this is the one that makes us even got the regional recognition of investing in SLAMTA, as well as accrediting adequate number of laboratories. And this one just shows you the distribution of laboratories per entire system. So you can see we have accredited all the national laboratories. Do you know the national laboratories? We have NPHL, we have Muhimbili Hospital, and the other branch of Muhimbili, Loganzia. So all the 3 laboratories, all the 3 national laboratories have been accredited. And then we have another group of super specialized laboratories such as Kibomoto, Mirembe, Ocean Road. All these laboratories have been accredited, and we are still struggling with just a few, Chato and Mtwara. So we are hoping to reach 100% even to super specialized laboratories. And we have gone further even to health center laboratories. They've been accredited. And we have reached even the health center laboratories for private sectors. So even the private sectors, you can see we have put the district level for private sector, regional level for private sectors, and we are doing good partnerships also with private sectors. Now, the challenge comes here on the percentage distribution of accredited scores. You can see that most of rapid tests and TB, which is junior expert, are mostly accredited than other analytical parameters, which is quantitative parameters. And one of the contributing factors is inadequate and interrupted supplies of reagents and equity availability. So that's the area that we are going to discuss further with our partnerships and agreement with our colleagues from Germany to see how we can increase these scopes of quantitative tests, including the tumor markers, HPV, and clinical chemistry in the accreditation scopes. This is accreditations for National Blood Transfusion Services, and you can see that the National Blood Transfusion Services, the dedicated ones have been accredited, and we are adding now 5 centers in the accreditation. Many questions. I know that I want to preempt you in sustainability questions. I usually put the questions on sustainability component. So in the sustainability component, we have tried to invest in the sustainability areas, including we have trained 81 members to support mentorship for both SAMTA and laboratories accreditations. Initially, we were getting these services from outside experts, CSI and other experts from outside the country. But now we have in-country mentors, and all the tremendous achievement you have seen in the previous slides are contributed in with these credible mentors in the country. And we've trained 37 ASLM certified auditors. So we just contact with ASLM, and ASLM just arrange the auditors within the country. So we are not importing anymore. And we've created a pool of 23 SAMTA TOTs and other 5 certified TOTs through virtual platforms. And all these are within the country, and we are not procuring the services outside the country anymore. So the first batch that will be accredited from the last financial year will be within the local capacity building, and we are going to measure ourselves from the investment we've done so far. So another good thing is the national, zonal, and regional hospitals. They are allocating budget for surveillance and accreditation. We were depending 100% on regional IPs, but now some of the hospitals are doing joint efforts with the regional IP to pay for accreditation and surveillance. And another thing that I didn't put here is the PT production. We were importing all the PT. Well, when we were speaking about 2010 up to 2015, we were importing all the PT from outside the country. We were buying the CD4, we were buying the clinical chemistry and everything from outside the country. But now, the 3 labs that we've dedicated, they are producing the PT within the country, and now we are running for accreditation of the 3 batteries, and then we will start distributing the PT even outside the country. But still, we have some challenges. We have some challenges in major changes of laboratory leadership and ownership. This one draws back the facility quality management system. You can see like the laboratory which was previously owned by government and now it's owned by private. And they've changed all the management and laboratory staff. This one draws back the quality management system and it affects the accreditation status. And we have seen the building reallocation, especially in most of the regional laboratories and district laboratories. And this affects much because we are not preparing the lab when it goes to the new infrastructure. And we have seen lack of ownership in QMS initiatives in budget allocation in some of the facilities. And we don't have in-country accreditation body. You see all this, the accredited lab, they've been accredited by external accreditation provider. So if we would have in-country accreditation body, we would be speaking about 300 laboratories accredited by now. But because of the costs, we are moving slowly. So we have way forward for that. We ought to develop the legal framework for accreditation body here in Tanzania, and we have started the progress, and the Attorney General has approved the process to proceed. We wish to sensitize the facilities, and most of the facilities, some of them are here, to allocate budgets in supporting the quality management systems initiatives, including procurement of calibration services, training of personnel, just to improve the quality of our services. But also to develop contingency plans in case we are moving from one building to another. We need to have contingency plans to ensure uninterrupted supply and uninterrupted quality services during the process. So all these we wish maybe we can also include the partnership with other agencies to include and scale up the EQA and PT production within the country. So I would really wish to acknowledge all the partners, all the partners that have been working with the Ministry of Health to ensure that the EQA quality management system accreditation is sustained. Na kazi endelee. So for those who don't know Kiswahili, na kazi endelee is what? What do we say? Okay, thank you so much.
Thank you, Jacob, so much for this insights in what is going on here in Tanzania. And again, we will leave a discussion for the end of the session. And now it's a great privilege to introduce Mr. Saif Abdul Kizili. He is representing the National Health Laboratory, and he is Laboratory Quality Officer at the National Health Laboratory, and he has more than 10 years of experience in laboratory quality and epidemiology. And you are also working in the past on outbreaks, the COVID-19 outbreak, the Marburg virus outbreak. I'm very intrigued about the Marburg virus because the Marburg virus was discovered in my city, Marburg. It's one of the hemorrhagic viruses, so that's really amazing. So we are very much looking forward to your presentation.
Thank you, guys, for the introduction. Good morning. So my colleague, Mr. gave us an overview of the QMS implementation of Tanzania. So basically, we go straight to the proficiency testing service in Tanzania, and this is the national testing. So basically, I will give you the overview of how the PT are being used, how do we do the shipment, and all the way to the submission to the panel results, and I will share some challenges and way forward. So basically, National Public Health Laboratory is under the Ministry of Health by leadership, and we are mandated to do two main functions. The first one is to coordinate public health function within the country, including disease surveillance, epidemics, preparedness and response, and the laboratory that quality research. And the other one is organize proficiency testing services for medical laboratory. So we are mandated to make sure all the medical laboratories receive the PT panels and their EQAs within the country. So the scheme offered, basically we started the PT production in 2021. We have 3 years of implementation, and we started with 3 scopes that were proven picture, HIV, THS, and HIV syphilis. But now we have scaled up to more of 16 scopes that range from hematology, clinical chemist test, microbiology, serology, and virology. So you can see there, we are even capable of producing culture swab samples, which were a bit challenging to get the microbiology EQA within the country. So this is our PT calendar. In Tanzania, our government year starts on July and ends in June. So you can see we do enrollment. I think in the red there, we do enrollment on August, and the shipment starts on the first shipment will start in September. So basically, we have 3 rounds of PT within a year to some of the tests and most quantitative tests. And for the few tests like culture swabs for bacteriology and early infant diagnosis DBS for HIV, we have 2 shipments in a year. So in the green ones are the shipment, and the blue one are the dispatch of reports, where the participant receive their feedback after performing the EQAs. So we always do enrollment once per year. Usually we do it on August, and then after enrollment we do it for the year end. When the year ends, we do enrollment again. This is because the labs has to be enrolled every year, because you might find the lab change the scope, want to add the scope, or to drop some of the scope. So we usually do it in a year basis so that we can scale up our resources and plan for the whole period of the cycle. The enrollment basically facility should fill out the application form, submit the MPHL via email, and return the hard copies of the proof of enrollment. And also after this, we provide them with the PT scheme protocol where they can read our instruction and the way to participate. We give them the calendar as I've shared and the appeal procedure. This is the procedure which helps them, because sometimes this is like exam. So we send the sample, we know the results, you test, you send your results, and we give you feedback. Yet sometimes people or the laboratory might have that thing that probably we did right, but they give out the wrong results. So we have the procedure to appeal. So they have to appeal, and we respond to all the appeals. The aim is to improve quality. So it's not as we want to highlight who is not performing well, which lab has poor quality. So that's why it is very encouraging to have the procedure to appeal and make the facility confident to the scheme and feel free to participate. That's why this appeal procedure is important. So, as Jacob explained, also the PT schemes covers all the types of the facility and we are going further even to the testing sites. As speaking to the testing site, these are not the laboratories. We have point of care which offer some tests like HIV testings, some very simple tests. So we even enroll them for the PT and provide them the PT for the test. So these are the number of the laboratories that we have enrolled so far. That's conducted the malaria microscope. But so far we have managed to cover 597. So we'll see what are the challenges later on my presentation, and probably can open the room for discussion. This is how we pack the sample before shipment, and we always pack them in the boxes, and the boxes are packed per regions. You can see there we have Dodoma, we have Morogoro. So the sample goes to the region, and from the region, the sample are distributed to the laboratories. So this sample they are ready for shipment to designated regions for distribution to the facility. How do we receive results from participants? This is the place also where we have the challenge. Currently, we receive the results via email. We have a office email that all the participants are supposed to send their results, and those are the email that will be used also to send the feedback to them. So we have a big challenge there. I'll also explain on the challenge section. So there it is. The challenge we are facing in the PT production, we have no electronic system for result submission and result analysis. So all of this work are done manually. So you can imagine more than 500 facility with 14 tests. So each test has its PDF that has been sent to laboratory. So we are supposed to download all the PDF report. For example, if I go back and show, we have here, we have 402 facility for HIV, hepatitis B, hepatitis C. Yes. So you get 400 times 4. These are the 4 tests. So it's 400 times 4. And when you come to full body picture is 150 times 2. Malaria microscope is 1 test. So all this number times the test that's our performance. Those are the PDF we are receiving. We download those PDF and then we copy the result to the Excel for analysis. So we are prone to transcription error. So we have many ways to minimize these errors, but if we have the electronic system that can coordinate, because there are software that can receive results and analyze the results and send the feedback to the participant. So that is the thing we are missing. Also, we have challenge on stability of samples. You know, when you want to send this sample has to be stable. To move sample from Dar es Salaam to the farthest point, maybe to Kigoma, let's say, sample they will travel by air to reach a point, they will go by bus, to some places they will by ship until to reach the facility. So some places it may take 5 to 4 to 5 days. To some places it's just 10 minutes from the lab. So we have to make sure the sample going to the farthest point had the same quality to the sample going to the nearest point in the time. So the stability, for now at least we are capable of stabilizing them for 30 days. But we wish they could stay longer because I know these samples are used in the facility for their calibration. They're still using some for some other purpose of ensuring quality. So also we have the knowledge gap that we are working on right now. We are still not capable of stabilizing urine and stool sample or creating the simulated sample. So some other EQEs, we need to have simulated sample that can be treated as a urine or stool sample and being analyzed by the facility. So this is the knowledge gap that we are having and we are working on it. Probably on the coming financial year we'll be having this test on board. That's why on my list you haven't seen the urine or stool sample, and most of the question might be, I expect we might have. We have challenging UTIs results and people are really keen to know what is going on in our facilities. So, and we are really working on that, that's why I'm putting as a challenge. Also, we have capacity of preparing simulating sample, as I explained. Also coverage, I think I explained this. Yeah, we coverage, you have 2 issues. The number of scope that we are supplying to the laboratories are not enough. The labs test more than, at least the health facility has more than 96 tests, I think, if I'm not mistaken. But we only have the capacity of around 15 to 20 tests. So that's the issue of the scope. And the facility knows we still have some gaps because we have a range of 60,000 laboratories in the country, but we have managed to reach only 500. So going forward now, the current electronic system for result submission and the analysis is currently under construction. So we are expecting to have it next year. And also we are building capacity on preparation of PT materials for complex scheme like urine and stool, and this is where our friends from Germany comes in to collaborate with us and help us to increase the scope in seeing how can we have even the simulated sample for some of the complicated schemes. So that was all for PT overview. My acknowledgement goes to all of the stakeholders, donors, and for the anyway pushing this way forward. Thank you so much.
So thank you very much for this excellent presentation. I think this is great overview about how the program is organized here in the country, and also highly appreciated that you referred also to the challenges and the opportunities. And I think we have time to discuss this also later on. With that, I would like to ask Dr. Anja Kessler to come to the podium. She is the head of the reference laboratory in Germany, and she is a really internationally known expert on quality control and quality issues. She is advising many international organizations, including also IFCC, International Federation of Clinical Chemistry. And she will give us now an overview about the situation from the German perspective.
Yes, thank you. Thank you very much for the kind introduction, and I also would like to welcome you here in this forum, and I'm very happy to be here in this symposium and this congress. It's a really good experience to me, and now I'm very, very happy to give you some information about our work we are doing, and I think there are some parallels we have seen before the presentation, so I think we will have plenty of things to discuss on. First of all, this is my agenda, and I will show you something about who are we and what is our motivation. I will give you some examples of our EQA surveys where we can see that most of you are participating in EQA schemes. There is comparability and also standardization possible. And last but not least, I will summarize these. So, who are we? The RFB, the Reference Institute for Bioanalytics, is a non-profit organization, part of a non-profit organization, the Foundation of Pathobiochemistry and Molecular Diagnostics. And this institute was founded in 1971 and is situated in Germany, and we have 3 locations, and you have some slides here from our locations, and we are on the top is Bonn, then Cologne, and below is Hanover. We are actively contributing to the development in the fields of sciences, metrology, and accreditation, and we are providing EQA schemes. That's our main business, and we are accredited according to 7043. This is the standard for EQA providers, and in addition we have a national regulation we have to fulfill so that we are allowed to offer this service in Germany. And one part of this requirement is that we have to provide target values which are assigned by calibration laboratories. These are values which are used as target values and which are traceable. So I will come back to that in a very brief way later. So this is one slide summarize our survey pathway. So, and it's similar to those we have heard by Saeed in the last presentation. We have a registration in the beginning, and we have to buy or produce EQA materials which we can send out to the participants. The shipment takes place on several occasions. Normally, we provide every EQA scheme 4 times per year, and for things like microbiology, 2 times per year. And then the survey period starts, and then it's the job of the laboratory. So they have to analyze our samples we send to them. They have a certain time, sometimes 2 weeks, or sometimes even just 1 week if the material isn't that stable. And then after the deadline, they have to report the results to us. And we are in the lucky position at the moment that we have an electronic way to do so. And I know your pain to transfer all the PDFs to your system. So we did that in the past as well, and I know it's enormous work to do. So we have transferred that to an electronic way some years ago. So then we evaluate the results, and after that we look, well, does the participant fulfill the requirements we have stated, then he or she will get one, or they will receive a certificate, and otherwise not. And after that, of course, the people get their evaluation and certificate, and if there are any questions, we have discussions with them about the outcome of the survey. And I think that's a very, very important point, since it's not just receiving a certificate, but you have to work with that certificate, you have to look at the result, and you have to try to improve if there is some need to do so. So why are we talking in general about that topic? And in 2021, the WHO states Patient Safety Action Plan, and this very long document, about 40 slides or something like that, and I just had some items. And one is that healthy technologies are essential, and I think that's something we all agree on. And if they are working in a correct way, we have to make sure that these IVD equipment is safe, that the quality is high, and that the performance is of the use we intend to need. And so we need an approach to demonstrate these three topics in a comprehensive and transparent way. So we have to improve the availability and the quality of information, so that we then can improve our daily work. So this is something Harald said in the beginning in his first presentation. The decisions made in medicine are based on laboratory values. So these results are important for diagnosing, risk assessment, and the choice of treatment. So we have to make sure that these results are accurate and precise. Otherwise, we have a basis that probably is a misleading therapy to the patient. And I think that the EQA tools are a very important and transparent tool to monitor quality independently. So if you're using a test procedure, you have a calibrator and sometimes also internal quality control from the manufacturer. But in an EQA scheme, you have the possibility to monitor your system with independent samples where you don't know the value and even the manufacturer do not know, and to compare these to your colleagues in the other laboratories. So, and now I would like to switch over and show you some examples and the outcome. So this is a result or a diagram of results we received in 1994 for glucose. And you see the results of our participants. Each laboratory received two samples, sample A and sample B. And each dot in this diagram marks the results of one laboratory. So on the x-axis you see the result of that laboratory. And if your dot is within the square, then you fulfill the acceptance limits of the survey, and you will receive a certificate. And you see that the dispersion of the dots is extremely large, and several of the dots are outside. And today, in 2023, the situation looks like that. So there's an incredible increasement that most dots are within the square, and they will receive a certificate certificate. So the general performance of the laboratory improved during these 30 years. And so it's not just the benefit or the result because they are participating in the EQA scheme, but it's a way to display that there is an improvement. And it's a regular feedback for the laboratory to see where is my dot. Am I outside or inside? And did I improve somehow? So this is also some results for troponin I, and it's a bit like an example Harald showed in his presentation. This is also the results from one survey, and each dot, as it's the same concept and form. And highlighted in blue, within the green square, you see the results of the tests, the results of participants using the test kit A. So there were 20 dots, and you see the median for sample A and the sample B. And when you look at the next test procedure from a different manufacturer, you see that the dots are in a complete different area. So we have 148 participants, but the median is just half for sample A, and B is even also lower. And we can go through, we see test kit C, it's even more low, and then sample D is one higher, and sample E, test procedure E is also on the top of the screen. So what you see is that you have a comparison of results for one and the same sample, and you can compare them within one test procedure. So you have an answer to the question, am I right with those laboratories that are using the same test procedure as I am doing at a certain time? But you cannot compare your result with a laboratory that is using a test procedure from another manufacturer, because they have completely different medium and there is no relationship between. And also, if one new generation of a test procedure you're using today in your laboratory is coming, then probably you have the same situation that you have to clarify if there is comparability or not. So what we are looking for is a system where we have precise comparability, and if we want to know who is right, which test is right and gives the right result. So for troponin E, there is no system currently available to standardize this system. So I have an example for cortisol, and here we have an internationally accepted program for standardization. And we are using that system, so we have a target value that is assigned by our calibration laboratories I mentioned in the beginning, by reference measurement procedure, and this reference measurement procedure based on gas chromatography mass spectrometry. And then we have just one target value, and independent on the manufacturer or the test system you're using, all were compared to the same target value. And you see it's quite working very well, and most of the participants are within it. So we have the possibility to show optimization and standardization by the results of an EQA scheme. And we also can see if a manufacturer is changing this process in test conditions, calibrators, or test system by next generation. So you can see that in a timely and transparent manner. And this is a slide you've seen before. And in April 2023, we had an additional manufacturer, and yes, you can see, the dots are on the lower limit for sample B. And this sample B has a low concentration. And so you see that these samples, these results aren't within the box. So these participants do not receive any certificate. And of course they call us, and we call the manufacturer. And we discuss that with the manufacturer, and they look through their system, and then they offer a new calibrator because they realize that there is a problem in the calibration and the lower concentrations. And they remove and send out the new calibrator, and that's the situation today in June 2024. So it's an improvement for the outcome of the EQA scheme, but also, of course, for those who are measuring patient samples with these test procedures. So, I think, and I hope, I could show that's important to cooperate with the laboratory, EQA provider, the IVD industry, and also the regulation to improve quality assurance in laboratory. And to keep on going that discussion, we need data, we need facts, and we need open discussion with comprehensive information on the evaluation. And so we probably also can add some findings and comments. That would be the best way to talk to each other and improve the situation. And of course, we have to investigate and develop new EQA schemes. Like the best example is Corona and SARS-CoV-2. We did not know that in 2019, but after that, everybody knows that we have to react on that. We have to react on the manufacturer, by the laboratory, and by the EQA system. So, in sum, our motivation is that we think that quality infrastructure is a combination of quality assurance for patient safety. And we want to show comparable results. And actually, at the moment, we do not receive only results from Germany, but all over the world, we get our results back. And we cannot identify those dots that are from outside from Germany. So they are completely equal. But important is the performance of each laboratory. So we have the capacity and the possibility to offer these data online on our website, so you can have access to these evaluations with, I have shown you before. So of course they are confidential to each laboratory, so you cannot identify the dot of one laboratory, but you see the overall results on that website. So it's important, and I would like to invite you to visit that website to look at these results. And then you can use these results, for example, for education of staff or technical people. And of course, we all want together improve the performance of the lab and the IVD manufacturing system. So thank you very much for your attention.
Thank you very much, Anja, for this excellent overview. May I ask the speakers to come? Anja, please here. May I ask our speakers to come up also here to